class this afternoon. I appreciate your attendance. This is our CTR, to remind you, this is a CTR Enrichment Series, which is our seminar series. And I'm delighted that Dr. Davene Wright is here from the Center for Healthcare Research and Pediatrics at Harvard Medical School in the Department of Population Medicine. I am blessed to know Davene through the network of health services researchers in pediatrics who sort of let me, at Harvard, to let me tag along with them at times. And so I'll just give you a brief snippet of her greatness, and then you can go read the rest of it as we allow time of her bio. She is an assistant professor in the Department of Population Medicine. As I mentioned, she's a healthcare researcher who uses decision science methodologies to design interventions and promote policies to improve the management of pediatric chronic diseases. And she aims to improve the supply of and demand for efficient healthcare that can improve the management of pediatric chronic disease with a focus on obesity in childhood. And then to just list out her many accomplishments: a BS in polymer and textile chemistry from Georgia Tech, where she was a president scholar, a Ph.D. in health policy and decision scientist from Harvard in 2012, where she also received an NSF fellowship. I just had to get that in. And it goes on and on. But with that, I'll turn it over to you, Dr. Wright. And if you have questions, everyone, put them in the chat. And we will hold them to the end. But if you have any clarifications, we'll pause to get those answered.
Okay.
Please.
Well, thank you for having me. And I will say, it's sad, I've never used that textile degree, man. But people are always just like, what in the world was that? And it is because no one wants
Not yet, not yet.
Well, you know, no one wants to study textiles, as it turns out, and so they will give you scholarships to do it. That's what we do. But today, I'm not going to talk about textiles. I'm really pleased to talk about the work my team and I have been doing in this project called Invested, which aims to design a patient-centered incentives program to increase adolescents' adherence to self-care for type 1 diabetes and improve their outcomes. So this is not new, or, I mean, there are some things I think are particularly novel, but people have been using financial incentives for a while, since the 70s at the very least. I mean, they're bribes. But in 2015 or so, this group out of 10 started doing some really interesting work with financial incentives, and not just saying, you know, we're going to pay you to do things that we think will improve your health, but also we're going to mess around with the way in which we pay you. So they use gain frames where you got no money, but then every time you engage in a behavior, you got 10,000 steps a day or whatever it was, you would get a little bit of money for that day. They also use loss frames where they would say, okay, you're going to get $10 at the end of the week, but for every day that you don't do the thing, we're going to take a little bit of money away. They build upon prospect theory and loss aversion there, because people really hate losing. And so they'd be more willing, in theory, to do something to avoid losing money than they would be willing to do something to get money. And they also played around, interestingly, with some lotteries that also build upon some of the heuristics we use for decision making and conceptual biases that we as humans have. And so this work is super interesting. And generally, you know, incentives work for adults when it comes to smoking cessation, getting people to exercise for weight loss, for improving glycemic control, getting people to attend primary care visits and engage in health screenings, and also for adolescents with type 1 diabetes, getting them to check their blood sugar. However, incentives sort of like only work. And so with the exception of smoking cessation and physical activity, for those who have had a recent cardiac event, once the money stops, the behavior stops. And I think it's because people are incentivizing patients to engage in behaviors where the patient is not necessarily seeing the health outcomes. You have to pay people to do things that they're going to be able to observe, make them feel better. And if not, you're going to have to pay them for a very long time. I don't think the goal with financial incentives is to pay people forever. I think it's to pay people for long enough that they're motivated by the health improvements that they get as opposed to the money. But we started thinking intensely about financial incentives and whether they can work for kids. And like, if you have interacted with a child, which a lot of you in pediatrics have, or you may have children of your own, you know that kids can be bribed, right? We do the M&Ms thing for potty training. If you get a vaccine, you know, you get ice cream afterwards or a sticker. If you've ever been on a plane and if you give that kid that iPad, they will not cry, right? Like, drive for them, you can incentivize them to behave on a plane using technology. So I think to the degree that these actions create changes in desired behavior, whether that's long-term improved health, a love of reading, if anyone ever participated in the Pizza Hut Book It program as a child, or, in the case where you're trying to prevent a nuclear meltdown on a plane, I think it's fine to incentivize kids. But we do need to think about we start thinking about whether incentives would work for teens with type 1 diabetes. It's a pretty high-risk population. Among adolescents with type 1 diabetes, fewer than 20% have good glycemic control. Adolescents is the period for type 1 diabetes that is the most turbulent. I didn't know a lot about diabetes before I started this project. I do have a chronic disease myself, but I have arthritis, and so it's cyclical, right? You have bad days, you might have bad weeks, but it's not every day. And the same with diabetes type 1, is it just feels like it's pervasive. It invades every aspect of your life, and there's a lot of planning that has to happen. And for adolescents, what we heard is that they just want to be normal, and it's hard to be normal when you are wearing a technology device to manage your blood glucose or your insulin, when you have to stop to have a fruit snack because your blood glucose is low, when you have to, maybe can't go to Starbucks and order the same things that your friends are ordering. It's really tough. There's also, I learned, a lot of family conflict within families of kids with type 1 diabetes, a lot of nagging. And so we'll talk about that more, but it is a tough condition, I believe, to manage. And so we want people to do better. And so thought about, well, what if we use these financial incentives to pay them to do better? And we were not the first ones to do this, nor will we be the last. There were many studies that preceded ours and many that came afterwards. Most of them use financial incentives to look at the frequency of blood glucose checks. So can you check your blood sugar more often? There are, however, 3 problems that we see in the existing literature. And I think these are what I can consider a mistake that people continue to make. And a new study that's sort of like a Me Too study comes up every couple of months. The first issue is that type 1 diabetes self-care goes far beyond glucose checks. At Boston Children's, I think about 80% of patients are using some form of technology to manage their diabetes. No one is doing this sort of manual finger prick anymore. People are using insulin pumps, they're using continuous glucose monitors, they're using insulin pumps combined with continuous glucose monitors to have a closed loop, almost artificial pancreas situation. And the outcomes are evolving from being about whatever your blood glucose is at that moment, looking at time and range. For those using continuous glucose monitor, what percentage of the day is your blood glucose within an acceptable level of range, not too high, not too low, the Goldilocks just right. We need to pay for things that work. And I think people, I don't know the literature off the top of my head, actually, probably should, about the relationship between the frequency of blood glucose checks and your hemoglobin A1C or other adverse outcomes of type 1 diabetes. But just because you check doesn't mean you do anything about it. It just means you check, right? You can check and still be high. You can check and still be low. But what matters is that you check your blood glucose and you adjust something to fix it. And I don't think that's what interventions initially were doing. Also, I think whatever structure we come up with needs to be able to adapt to changes in technology. These are the technology we have now. They're not necessarily a technology we have in the future. Do we have to do more RCTs in the future to come up with a new strategy because there's a new form of technology? That's annoying. So when we develop incentive programs, we want to develop something that's flexible. The second issue is that we don't know how much to pay these kids. And so some studies base allowances or base incentives on the amount of a kid's allowance, which is weird. It implies that taking care of your diabetes is a chore, and B, as valuable as taking out the trash. I think a lot of times people are just guessing, and they are going based on their budget. And so when I approached this question, this is the core problem I wanted to solve. I'll explain later how I wanted to solve it. But we came to learn in this research that we don't even understand what money means to adolescents. For some, it meant gift cards so that they could shop online. For others, it meant Pokemon cards. For some of them, it was a bribe. Others considered the money a family contribution. Money in this population is complex. And then the third issue with incentive programs elsewhere in the literature is that there's little evidence about whether things that work for adults should work for kids. And so a lack of evidence-based what we are incentivizing again. And then also I think the interventions as designed were a little bit paternalistic. It's unclear whether they were very patient-centered in terms of what we're paying kids to do and how incentives were perceived by family. Like, how does a family literally feel about the fact that their kid is getting money to take care of their health? There's a lot of diversity of thought there. And so my colleague, Holly Woodeman, has this great paper about like what makes for a good health intervention. And I think these are two criteria one must meet. She talks a lot in this paper, I'll mention it later, about ways to assess people's preferences and values. But we do need to do that, I think, proactively in the development of interventions and not after the fact. So when I mentioned that I had a thought about how to figure out how much we should pay people, I wanted to use this marketing tool called the discrete choice experiment. And so essentially I thought, okay, corporations don't design products in theory that people don't want. Healthcare is a product. Why shouldn't we use these marketing tools to figure out the products that patients want? And so essentially, in a GCE, I'll show you, you see two products side by side and you say, which one do you want, A or B? And then you change those products, which one do you want, A or B? You make a choice. And based on what choices you make and the products that we know we showed you, we can tell what product characteristics you like most. Like, you were always picking the laundry detergent that is scent-free, right? We can tell how much more you like one characteristic of that product more than another. And we can also look at the ratios of your preferences for those products or attributes of those products to figure out what trade-offs you're willing to make between product characteristics. And generally, DCEs have high external validity for predicting consumer behavior. And so things that people say that they like, they end up purchasing in the future. And so we wanted to use data from this structured data preference survey to figure out what the precise trade-offs were that adolescents were willing to make between monetary payments and engagement in specific behaviors that were tailored to their diabetes technology use and achieving a specific outcome. And so here's what our survey looks like. Essentially, as I mentioned, you have two products. On this example, we've got reward A, reward B. I say it's a marketing tool. It's also a tool that has deep roots in economic theory. And so we have 3 attributes total. The first attribute is the monthly, is how we structure the incentive. As I mentioned, we could do the gain frame where you earn points for each goal that you meet, or we can do the loss frame where we say, okay, you're going to get $60 worth of points, but you're going to lose points for each goal you don't meet. And we say points as opposed to money because we wanted to create this, or we suggest creating this like virtual marketplace where you can trade in their points for whatever goods or money or whatever they want. The next attribute is the monthly value of the reward. And so in reward A, it's $30. In reward B, it's $60. And then the next attribute is what are we paying you to do? And so here we're being very generic. We're saying something that is easy for you and something that is hard for you. And we actually tailored the survey to the type of technology that people were using. And then for each type of technology, we said, what is easy for you to do? What is a sort of neutral behavior? And what is hard? Because that could be subjective. We had one kid who said when she did her site change and moving around her CGM that like she could only do it if her mom did it for her and she screamed while her mom was like doing the insertion, right? But another person said like, that doesn't bother me, I have no problem with that. And so I think paying people for things that they themselves struggle with and having sort of goal-based financial incentives that are personalized is another way that we can have some innovation in this space. So we ask people to choose reward A or reward B for this one specific option, and then we change the options. In this case, now we're looking at $50 versus $40, a loss frame versus a gain frame, and a medium behavior versus a hard behavior. We do this 10 to 12 times. And this is how I approach the study, and this is what I, as a decision scientist who uses these methods extensively, wanted to do. In retrospect, one thing I want to do is talk about the value of interdisciplinary research today. This is a pretty shallow thing to do. It's all I do in this project, which is what all I wanted to do was pin down the amount of the payment for a certain task. That was limited. And by bringing on a really interdisciplinary team, a diverse team, I think we were able to make this study very robust and deep. And this sort of goes to like a rant that I have around collaboration. As Beth mentioned, we met in the pediatric space. I'm not a pediatrician or a clinician, but I do a lot of pediatric healthcare research. And I think as a PhD, who for many years was in the clinical department, people approached me and they would say, hey, Davene, I want to put you on my grant. I want to do this. I want to do this economic valuation. Can you do this for me? And now that I'm like a bit into my career, I realize that's not the way to go. When you have someone who is an expert in something that you know about, you're probably not an expert in that if you're asking for their help. You should not be assigning them tasks. You should be saying, this is my goal. I think this is in your wheelhouse. Can we discuss this like mutually agreeable research project and how it would be interesting to you and helpful for me to reach my goal? Because you are not an expert in someone else's topic, you can't possibly know all the different options. And it's better as an interdisciplinary research, I think, to be sort of collaborative as opposed to prescriptive when you're bringing people on board. That's definitely being prescriptive. It's something you can do when I think you have like an analytic core or some, a stats core maybe. But even then, like, we're not statisticians. Like, they know a lot of things that I don't know in ways to approach different problems. So I think what I did, thankfully, in this, I think it made it so much better in this study, was to approach people and tell them my goal and have them bring their disciplinary expertise to the table. And so I really do have the pleasure of channeling my inner George Clooney today. If you remember the movie Ocean's 11, and like George Clooney doesn't do anything, right? There's a guy who like does the bombs. There's a guy who's like the acrobat, right? There's a money guy, and George Clooney doesn't do a thing. And I and the investment team feel like George Clooney, and I just have the pleasure of showing up at the end of the study and telling you about all the wonderful work that my teammates did. And I know we usually do this at the end, but I want to introduce it now because I want you to understand how this team shaped this work. So the work was funded by the American Diabetes Association. Faisal Malik is our lead endocrinologist, pediatric endocrinologist on the study. He's an expert in adolescent health for type 1 diabetes. Seema Shah is at Northwestern and Murray Children's. She is a JD by training and a bioethicist, and she led our ethical analysis. Jessica LeBlanc is our rockstar project manager at Harvard Pilgrim. Chan Chen is our statistician. Joyce Fraser is a psychologist, PhD psychologist who focuses on resiliency for youth with diabetes. Kirsten Centuria is a qualitative researcher. Kate Poker is the head of pediatric endocrinology at Seattle Children's in UW. Kate Garvey has the same role at Boston Children's and Harvard Medical School. And then our research assistants, who were amazing, Carolyn, Kristen Chalmers, and Maria Manzueta, who, when our patients would call the phone line and like, the RA was on vacation or they had left for the day or something, and I would pick up the phone, they'd be like, where's Kara? I only want to talk to Kara. They were like, who are you? And I'm like, it's my study. Like, anyway, just to say that the research assistants are highly valued members of our team and the most recognizable apparently because the parents in the study did not even care who I was. So I have a couple of goals today. I know we're like almost through, but I want to talk about which financial incentive structures may be appropriate for adolescents. Talk away a bit, as I have already, about ways to align health interventions with patient and family priorities, and then talk about our next steps for implementation. And then, as I mentioned a little bit, I think it'd be great to talk about how our interdisciplinary process for conducting patient-centered and policy-relevant research works. So first, qualitative research is the foundation for our project that both forms the study design or informs the study design and builds our connection to the data. I think a lot of quantitative people perceive qualitative research to be less robust, but it is so useful as a critical element for storytelling, and I encourage people to bring on a qualitative researcher for the team. We did 4 focus groups with families, focus groups in 4 cities in Seattle. We had 12 focus groups total. We had focus groups with all adolescents and a focus group with all parents. While we have limited geographic diversity, and if you know Seattle, you'll know it's not surprising we have limited racial and ethnic diversity. We do have a lot of economic diversity, and about 30% of households have household incomes below the median in Seattle. And it's really not just like the absolute number that matters, but where you are relative to other people when it comes to those disparities. The objective of our qualitative research was to explore adolescent and parent perspectives on using financial incentives to promote diabetes self-care adherence. And we essentially asked them, okay, what do you want to be paid to do? How do you want to be paid? We revisited that idea of the framing, and also the form of payment, the Pokemon cards, the gift cards, the cash. Like the idea of cash, when they hear the word cash, they think like actual physical cash, not like digital cash. And they're like, what am I going to do with like dollar bills? Like, where can I spend that? Which just makes me realize that I'm not 15 and I'm old. We also asked them, how much money is the right amount of money? That doesn't feel like a bribe, but still like would motivate you. We asked them if you were going to cheat, how would you cheat the system? So we could design around that. We asked the families how they felt the incentives would affect their intrinsic motivation, and also how they felt the incentives would lead to or resolve some family conflict. And long story short, we came up with this diagram about whether they're acceptable. And we essentially found that a lot of families did not believe in using financial incentives to improve their kids' health. However, their kids were so sick and they were so scared, they were willing to give it a try. These families' worst nightmare, or these parents, their worst nightmare, their kid's going to go to bed and they're not going to wake up, right? And so if someone is offering to pay your kids so that they can wake up in the morning, you will do that. They are so desperate for solutions. They are so tired of fighting. One mom, which I'm not sure if an accident, told a story about how she was really worried about her kid. In a two-parent household, there's always one parent who's like the worrier and one parent who's like the fun parent. And this mom woke up in the middle of the night, decided to check her son's blood glucose by pricking his foot, and then he accidentally kicked her in the face. And I'm like, I think he just doesn't want you in his bedroom in the middle of the night. And I wouldn't if I were a 16-year-old or 15-year-old boy, right? But there's a lot of fighting about like trying to keep your kids alive, and also kids wanting to be normal and forgetting to do things, and like normal teenager things that just you can't. There are bigger challenges when you have type 1 diabetes. And so essentially, if we thought that if they thought it would work, and if they thought it was urgent, then they were willing to try financial incentives. I'm summarizing this with not a lot of depth, but in the interest of time, I want to show you the full spectrum of the work we did. We could do an entire talk just about this. We also used some of the qualitative data and some other data to do an ethical analysis. So Seema Shah led this. We talked about like what are the ethical concerns of paying kids to engage in better self-care for their diabetes. We found that people thought the impact of this on family conflict would be mixed. Some people felt like if this sort of program would then be the policeman, like they didn't have to nag their kids as much because we were nagging them for them. They thought it would relieve family conflict. And some people felt like they would fight to say, like, if you want to earn your incentive, you need to do this, and this would actually increase family conflict. There were some perceived unfairness, like they hated the lottery idea. It's a very like adolescent notion to think like, wait, I put in the work, I should get the reward, I'm not get a chance at a reward. But they did not like the lottery, and so we ended up not using that in our RCT or in our discrete choice experiment. Some people thought that the loss frame, where we would take away money from like a pot at the end of the week, was unfair, but some adolescents, like a small subset, thought it would motivate them. Other elements that were unfair is if they had to share their incentive with family members. And then there was this interesting perception that lower income families would encourage sharing, which would lead to concerns for disparities in the effectiveness of incentives. Were they less effective for lower income families because the kids had to give up some of the money? And so what we got out of this was one, just sort of being able to evaluate, like, okay, this is what someone like in theory is worried about. What does the literature say about how this is valid? We learned that we need to plan for dishonesty by either using oaths to discourage lying, and also by trying to incentivize objectively observable outcomes, things they can't cheat about or cheat on. And we did ask them specifically, like, all the ways to cheat. We learned that because there's a lot of heterogeneity in preferences and perception of ethics, we need to personalize these programs. We also, in future research, identified some outcomes that were important. Monitoring whether sharing undermines effectiveness, so we need to collect data on did you have to share your incentive after the RCT, monitoring the impact on family conflict, and also creating a measure of intrinsic motivation. It's really hard to measure to see if this fixed intrinsic motivation. I'll talk a little bit later on if we get there about intrinsic motivation and how long you have to pay someone. My general feeling is, my hypothesis, is that the period of time during adolescence is so high risk and their health adverse health events would be so costly, it may actually be very much worth it to just pay them for all of adolescence. And by the time they reach young adulthood, they sort of normalize and are able to take better care of themselves without the financial incentive. That's my guess, but we'll find out. We also did another study looking at parental stress, building upon our qualitative work. And so using caregiver interview data, we looked at perspectives on the challenges and stressors of adolescents transitioning to young adulthood, and specific behaviors and coping strategies caregivers use to reduce their stress and prepare for the transition to independence. And we found that in part, strategies to foster independence should be gradual and phase out parental oversight. And so programs like a financial incentives program can help to phase out parental oversight. These can also alleviate parental stress and anxiety. And interventions like Invested are well positioned to improve this transition while reducing caregiver stress. But in our final RCP, the next one, we did also propose collecting data on caregiver quality of life. There's actually a specific caregiver quality of life instrument that one can use, like about like the quality of life of caregiving, which some people actually benefit from. And so for our proposed R01, Joyce D. Frazier, who led this work, is in charge of choosing and evaluating our psychosocial outcomes. And then the original point again was to do the DCE to look at the appropriate amount and structure of incentives. I'm not going to go through this example again, but essentially our attribute levels were the value of the reward, $20 to $50 a month, the payment structure, the gain or the loss frame, and the goal being rewarded, whether it was easy, medium, hard, or hard. We asked about 300 kids 12 questions, and we analyzed this data using multinomial logit models. And so again, for this hard example, this is how we ask people. So this is for someone who is not using fancy technology to manage their diabetes. These are the options that they had to tailor the questions to their devices. What's, is checking your blood glucose 3 times a day, 5 times a day, easy or somewhat easy. And so we gave them a list of behaviors for each device associated with improved glycemic outcomes. These are all evidence-based things. Ask them how difficult each behavior was for them to conduct, and then we pipe that information into the survey to customize it. And so here's an example for someone who's using a continuous glucose monitor. And so essentially we found that in spite of the fact that when in my research around this topic for obesity, parents were like, you don't pay me to parent my kid. But 50% of the decisions were made based on the payment value, like literally just paying them more, they thought would motivate them more. 30% of the decision on what was most important was based on the goal being rewarded, whether it's easy, medium, or hard. And although, interestingly, it feels like the thing that is most varied in the behavioral economics literature, people cared about the payment structure, the gain versus loss frame, the least. And so just like money matters. We also looked at the monthly willingness to pay, willingness to accept. And so essentially you would pay someone $10 or $11 more for a hard behavior versus an easy behavior per month. And they were pretty indifferent between the gain and the loss frame. There was a difference like $8 more, but I think that one was not statistically significant. And so I'm talking about an example related to type 1 diabetes. There are many other applications that have used the discrete choice experiment. So I hope that other people will consider using this method to design new health interventions. People have used it to identify drivers of vaccine hesitancy and willingness to pay for vaccines. Carolyn Foster at Lurie Children's and I have been talking about using DCEs to design health insurance plans for children with special health care needs. If you ask parents what services are important to them, they might list everything. But in the DCE, you can help parents and force parents to prioritize the characteristics of health plans that are most important. It's beyond qualitative research and beyond a simple Likert or rating scale. In other parts of my work, we are using DCEs to identify attributes of child health conditions that would cause a parent to seek care, so we can eliminate the noise in risk communication conversations, just talk about the things that people say they value the most. And lastly, Joe Zickasu at Vanderbilt, who's also a pediatrician, has used DCEs to identify the trade-offs parents are willing to make between travel time and access to enhanced primary care services. So I did want to talk about how to incorporate values and preferences into medical decision making, and I ran across this paper the other day that's so cool, where they essentially listed all these different ways that we could assess patient preferences. And then they rated them in like a complex mathy way to figure out how important they were to people. And then figured out like, what are these methods useful for? I'm not going to go into detail, but you will have this reference, which I think is so cool. And so again, not my figure and very hard to see, but you can see there's a list of preference elicitation measures and preference exploration measures, which is, this is more like hypothesis generating, whereas these are hypothesis testing, the elicitation of testing. And they identify the difficulty in using each method. Is it low cost? Is it quick? Do you only need a couple of sessions to do it? And they rate it on those scales. And then they classify these and say, here are the ones that are promising, and they have different groups. So this paper is great if you're interested in patient preferences, especially preferences that involve some sort of trade-off. Like there's a difference between a want and a preference. In a preference, you have to give something else up to get what you want. I would encourage you to look at this paper, and also to look at this paper by Holly Whitteman again and colleagues that evaluates different values clarification methods. But our RCT. So this was the ultimate goal. It simultaneously became the bane of our existence and the object of our desires. And so we wanted to do this RCT to see if these incentives work. Based on the DCE and our qualitative research, we translated preferences into an intervention. And so people were eligible for a daily payment, either gain or loss frame of $1.75 a day for engaging in a behavior. And if they achieve a goal, being either reducing hypoglycemia, increasing time in range, and reducing hyperglycemia, we also gave them a bonus of $2.75 a week. If you did not have any technology in order to conduct the trial, we gave you an insulin pen so that we could incentivize insulin administration. And 95% of our participants had a CGM. We generally found that people thought behaviors are easier to engage in than outcomes are to achieve, which is why the outcomes were the hard thing and the behavior was the easy thing. So that's how that was structured. We did the RCT using, or we proposed to do the RCT using a crossover study where everyone actually got each intervention and served as their own control. So treatment A was the gain frame, treatment B was the loss frame, and treatment C was the control. And then we were going to launch this study in March of 2020. You can imagine what happened. It felt like this, and our in-person clinic visits were gone. And we moved almost strictly to telemedicine. So we had to make some changes. The intake research visit and the collection of baseline hemoglobin A1C data, which is our primary outcome, was designed to be carried out when the patient was already in clinic. And so this became a problem when someone missed an A1C measurement. We adapted to analyzing A1C via blood spot when patients had poor internet access or no devices to upload their data, and also couldn't come into clinic. We would drive an iPad to their house and provide a hotspot. We were able to resume our research study in September 2020, but at that point, 50% of visits were still happening virtually. But it worked out. So the question is, were our adolescents invested? And so we were underpowered because, as I mentioned, COVID, we had trouble with enrollment and retention. And we did not see significant improvement in hemoglobin A1C, which is a 3-month measure, but we also know we were underpowered to find that. However, we did see significant improvements in time and range and the percentage of people who were meeting their behavioral goals. We did find that the gain frame was preferred or more effective than the loss frame. And at this point, I have to say there are 2 papers by Kenyon and Mosley, which review framing for behavioral incentives for pediatric populations. And I think there's very little evidence that these are appropriate or ethical or effective for pediatric populations. I don't think we should be using the loss frame for pediatric behavioral incentives. And we also found that there was no increase in diabetes distress or in family conflict. So those are all really great things. So what happens next? We need to think about implementation. And we hope that our intervention development approach will reduce the gap between efficacy and effectiveness for 2 reasons. One, out of our control, but we take advantage. Advocacy usually represents a situation where the intervention is performed under ideal conditions, and because of COVID, we were under anything but ideal conditions. But more importantly, the intervention was designed using mixed methods that considered ethical implications and patient preferences in what I feel was a very rigorous way. We went beyond qualitative interviews, which I think most people would stop there. We went beyond a conceptual model. And because we had already assessed acceptability, fairness, and willingness to accept incentives and tailor the incentive strategies to what families wanted and needed, we expected the acceptability of and uptake of this intervention in the real world would ultimately be very high. And so in this way, I think by using discrete choice experiments, we've created some efficiencies in experimental medicine. And so rather than having to evaluate the impact of every single combination of the various aspects of incentive structure, the value, the framing, the goal, we preemptively identified the likely non-viable incentive features. And so we could just focus on the ones that we think would work the best and have better hypotheses. We still have a lot of work to do. So, considering that we are paying people to engage in better health, it's really surprising that few economic evaluations have been done of incentive programs, and it's important to evaluate whether there is a business case for scalability of these programs. Effectiveness data in this case are insufficient for decision making. We need to fit costs, opportunity costs, benefits foregone, and different treatment alternatives. And we can use simulation models to systematically quantify not just what are the costs and health outcomes, but how do those track over time. We can forecast the long-term health trajectory of a person who receives this intervention or who doesn't, to look at whether we get fewer hospitalizations, fewer kidney issues, fewer eye issues as a result of this early glycemic control in the adolescent period. Without simulation models, you have to follow someone for 20 years to figure that out, and no one has time for that. When it comes to sort of implementation, also we need to think about the policy barriers. There are some rules and there's some legislation around limits on how much we can offer, what we can offer. That varies based on whether you're in the individual market or an employer-based market. How do we bill for this sort of thing? There are some rules about incentivizing kids that say you cannot incentivize kids for something that relates to personal responsibility. There are also specific rules about banning loss rate incentives for kids. But Medicaid does do support these, and Medicaid and CHIP insure about a third of kids in the U.S., mostly through managed care organizations that may be able to work with programs like this. For me, the big question is, what's the order of operations? Do you design a program that's effective and cost-effective, and do people adopt it? Or do you design programs that fit within existing regulations? I think it's hard to figure out what the process should look like without doing work around the cost effectiveness, the return on investment, and figuring out the basis for policies around incentives, what we're allowed to do, and how we can implement them in the real world. And so in June, we submitted this R01 where we are doing a bigger powered RCT, better powered RCT, where we're getting rid of the loss frame, but we are now looking at the impact of paying them for longer and paying kids more money to see if that improves effectiveness. We will secondly do a simulation model-based cost effectiveness analysis, look at the societal cost effectiveness and the return on investment from payer perspective, considering factors like, how often someone switches off of your plan. If we're not doing this from a societal perspective, you need to consider how long you're going to insure this kid if you're a payer thinking about implementing a program like this. Seema Shah is going to lead a policy analysis where she looks at the validity of policies around financial incentives, doing a 50-state survey of those. And also we will do interviews with health plan stakeholders to identify barriers to implementation. And specifically when it comes to the economic evaluation, I know, again, I mentioned this thing about people coming to me and saying, let's do a cost effectiveness analysis, see what it costs. It often is, the aim 3 that someone throws in to make their RCT more robust. But there's actually, it's beyond that. There's little guidance for how to use economic evaluation appropriately in implementation plans. And, I think we need to use economic evaluation tools and models to figure out value of information. Like, do we have enough information to make a decision to adopt this program? And what is the information that we can gather to reduce uncertainty so that we can make a decision? Like, what's the most important thing for us to know so that we can know whether we need to do like more clinical trials, collect more data, pricing differently, et cetera. We need to identify the costs that are relevant to implementation beyond just the cost of administering the program, and also do some translation of cost to the specific financing strategies. Typically the findings of economic evaluation based on clinical trials are rarely sufficient to inform decisions about how healthcare organizations and policymakers should actually finance investments in evidence-based programs. We're going to build what I hope is a cool dashboard for policy makers and decision makers to consume this information, knowing that research evidence is often inaccessible and hard to digest. And so we're hoping that building a tool like this, a dashboard, to support evidence-based decision making, to help stakeholders assess trade-offs between different program features, and view data that's relevant to their populations of interest that help to support decision making and research dissemination. That's another part of our future RCT. And then I think specifically, I live in the Department of Population Medicine, which is also affiliated with the health plan in New England. And so our department's affiliation with the health plan and our access to health plan stakeholders and data gives us a leg up on trying to evaluate the real world scalability of the intervention. So beyond access to New England health plans that we work with, we're hoping to leverage the resources of a group called the Healthcare Systems Research Network, which is a consortium of 19 nonprofit healthcare delivery systems to continue to do this work. So I'm going to stop there, and I'm totally open to questions. Sorry, I know there was a lot very fast. I'm very excited about all of this. And would love to hear from you about how these concepts might apply to your own work or any clarifying questions that you might have.
This was wonderful, great, wonderful, outstanding. I've been getting comments on the side, so thank you.
Thank you.
And I have to say, just both from an ethical perspective, a technical perspective, and a sort of clinical content challenges perspective, just fascinating.